So hello everyone, welcome to our Zoom meeting. Today we're going to start the fellowship meeting. I'm going to share the screen first, and Dr. Ryan Saleh will moderate this meeting. So go ahead, Dr. Ryan.
Hello everybody, Ramadan Kareem, and welcome to the Telegeriatric Research Fellowship, the weekly meeting. Today is March 25th, 2023. We are the Brown team presenting the meeting of today. We're gonna start our meeting by finance in geriatric medicine, presented by Dr. Tahani and Dr. Amal. You can go ahead, Dr. Tahani.
Assalamu alaikum. Can you see my screen?
Alaikum assalam wa rahmatullah. Yes.
So we present financing, coverage and costs for healthcare. The objective is to know and understand the different parts of Medicare and what each part covers, what Medicare covers, how the Affordable Care Act and MACRA are changing the way healthcare providers are reimbursed. Healthcare option for veterans. We'll also cover select terms related to healthcare financing, Medicare parts, including Part A, B, C, D, Medicare plans, hospice, Medicaid, dual eligibles, long-term care insurance, Affordable Care Act, Medicare Access and Cheap Reauthorization Act, MACRA, Department of Veteran Affairs, VA benefits, resource for patients and families, resources for healthcare professionals. So first we have some terms, we'll go through them. We have Advanced Alternative Payment Model, APM. This is a payment approach that gives added incentive payment to provide high quality and cost-efficient care. It can apply to specific clinical condition, care episode, or population. Then you have block grant. This is a fixed amount of money that federal government gives to the state for a specific purpose. And capitation is a payment for a fee to provide for services to patient, typically for a defined period. Carriers. Since Medicare inception in 1966, private healthcare insurers have processed medical claims for Medicare beneficiaries. Originally, these entities were known as Part A fiscal intermediaries and Part B carriers. In 2003, CMS, which is the Center of Medicare Service, replaced the Part A fiscal intermediaries and Part B carriers with AB Medicare administrative contractors. And then other terms include the Children Health Insurance Program, CHIP, provides low-cost health coverage for children in families that earn too much money to qualify for Medicaid. In some states, CHIPs cover pregnant women. Each state offers CHIP coverage and work closely with its state Medicaid program. Co-insurance is a percentage of costs of covered health care service for which patient is responsible after the deductible is paid. Deductible is the amount patient pays for covered health care services before the insurance plan start to pay for these services. Market basket index, this shows how much more or less it would cost at a later time to purchase the same mix of goods and services purchased in base period. Then we have the Medicare Access and Cheap Reauthorization Act of 2015, MACRA. This is a law that repealed Medicare sustainable growth rate and strengthened Medicare access by improving physician payment. It also reauthorized CHIP and merit-based incentive payment system, MIPS, provide performance-based payment adjustment to a provider Medicare payment for achieving outcome in quality improvement, improvement activities, advanced care improvement, and cost management. Modified adjusted gross income, the total of one's household adjusted gross income plus any tax exempt interest income. Quality payment program is a quality payment program improves Medicare by helping providers focus on the care quality. And it has two tracks, advanced APM and the MIPS. And resource utilization groups, RUGs, usually exclusive categories that reflect level of resource need in long-term care setting, primarily to facilitate Medicare and Medicaid payment. They are assigned to individuals based on data element derived from long-term care minimum data set. There is a standard order or hierarchy, and each RUG is associated with relative weighting factors. And then you have the shared saving program, a key component of the Medicare delivery system reform initiatives. Through the use of financial incentive, it aims to facilitate coordination and cooperation among providers to improve the quality of care for Medicare fee for service, FFS beneficiaries, and reduce unnecessary costs. In introduction to Medicare, it's a federal insurance program run by the Center for Medicare and Medicaid Services, CMS. It pays health professional and organization to provide health care for Americans who are 65 and more years old, disabled, or suffering from end-stage renal disease. As originally enacted, comprises two separate fee-for-services plans, Part A and Part B, which pay predetermined amount of for specific health-related goods and services. And 17% of the US population is covered by both plans. Then here is key feature of Medicare. We have Part A, B, C, and D. Part A benefits inpatient care, subacute skilled nursing facility care, home health care, hospice care, blood transfusion, and the delivery for hospital, skilled nursing facilities, and home health care. And beneficiary cost sharing in 2017 was for inpatient hospital deductible was around $1,300. And for physician, for Part B, benefit physician services, outpatient care, ambulance services, durable medical equipment, laboratory services, preventive services, and delivery for physician and other providers. And beneficiary cost sharing, monthly payment was in 2017 was $134 to $428. And deductible 183 is 20% co-payment. For Part C, the benefit include Part A and B services delivered through private managed care plans. Additional services, example vision, dental may be included. And delivery is for Medicare Advantage, MA plans. Part D is for prescription drug benefit. Delivery stands alone for Medicare Advantage prescription drug plans. And the average monthly premium was $35. And this is a Medicare as share for federal. It account for like Medicare 15%. Then we talk a little bit about the parts of Medicare. Part A, there is no premium for all the Americans and their spouses who have had Medicare taxes deducted from their paychecks for at least 10 years. And other may be able to purchase Part A coverage for up to $413 per month. This was in 2017, depending on how long they paid Medicare taxes. Part B, eligibility, age 65, entitled to Part A coverage, and citizen or permanent US resident. Premium are usually deducted from Social Security checks, and it covers some preventive services, such as certain vaccination. Some other vaccination are covered by Medicare Part D. Then Medicare services that not covered by either Part A or B plans include homemaking services, and those like home health aides may be covered temporarily for homemaking services if patient qualify for other skilled home health services. And also not covered by Part A, B includes driving safety evaluation, routine dental or foot care, hearing aids, eyeglasses, orthopedic shoes, cosmetic surgery, care in foreign countries. And then you have Medigap plans. These supplemental plans sold by private insurance companies that fill some gaps in Part A and B coverage. And there are 12 types from A through L, classified by benefit offered. You have A-level plans cover Part A and B co-insurance cost, and B-level plans cover Part A and B co-insurance cost plus Part A deductible. F and J levels plans have lower premium, but requires the insured to pay high deductibles. Medicare Select plans cover only selected physicians and hospitals. Medigap policies do not cover long-term care, dental care, eyeglasses, hearing aids, private duty nursing, or out-of-pocket cost for Medicare Part C. And within 6 months of initial enrollment in Medicare Part B, beneficiaries are entitled to purchase any Medigap policy on the market. This is the only open enrollment period available for Medigap. And after this period, Medigap insurers can refuse to insure individual beneficiaries or charge them higher premium because of past or present health problems. And then you have Medicare Part C, Medicare Advantage, Medicare managed care plans operated by private insurers, an alternative to fee-for-service Part A, B, and D. Private insurers hold contract with CMS, which is Center for Medicare Services, specifying that for each Medicare beneficiaries they will provide at least the standard Medicare Part A, B, and D benefits in return to fixed monthly capitation payments. Operate on risk-adjusted basis for each member based on the ICD diagnosis that are provided. To attract enrollees, most plans cover additional benefits and charge low or no premium, deductible, and co-payment. Patients must obtain their healthcare from the plan's network or providers with whom the plan negotiate price discount in return for patient volume. Enrollees must continue to pay their monthly Part B premium to Medicare, plus any additional premiums that MA plan charge to cover additional services. An enrollee can leave the plan and return to the fee-for-service Medicare's program. And here's a Medicare Advantage. Enrollment in 2008 include like 31% is 64% covered by HMO and local PPO 23%, the regional PPO 7%, fee for service 1% and other 1%. Dr. Amal will continue presentation. Thank you very much. And if you have any question, feel free to ask. If not, Dr. Amal can continue from the care party.
Thank you, Dr. Tahani. Assalamu alaikum. If no question, I will continue. Medicare Part D particularly cover outpatient prescription medication, open to all Medicare beneficiary who enroll in a traditional FFC and Medicare Advantage. Most Medicare beneficiary have this era of a plan to be selected from a premium deductible co-payment and different formulas. Same as Medicare prescription drug plan. To find plan finder, let enrollees enter their location and medication to compare. Part D option. This is a website for that. There is what's called donut hole, which covers the gap. When prescription drug cost exceeds specify yearly limitation. For example, in 2016, the limitation was 370. Under the ACA, Medicare gradually began closing as a donut hole. For example, in 2016, when reaching the limit receive a 40 discount on brand name of drugs and for 51 of generic drugs. After that, point plan cover 95% of additional drug cost. The coverage gap cost sharing level for beneficiary will be reduced annually until 2020, when the level will be set at 25%. Part D benefit change each year, and cost struggle can affect a patient adherence to medication regimen. This diagram shows Medicare benefit payment by a type of the service. That in 2016. Medicare Advantage represent about 30%, and house in patient service at 21%, and the other for house for home health, skilled nursing facility, hospital outpatient service, and other for Part D, which is about 14%. Hospice benefit under Medicare Part A, providing a wide range of medical coverage for a patient deemed to be within 6 months of death. Responsible for covering all drug for palliation and for management of the terminal condition and related condition. Medicare Part D cover prescription drug for a problem and related to terminal condition. In 2014, CMS stated that Part D is most need to use hospice care prior to authorization only on 4 category of drugs, like analgesic, antiemetic, laxative, and anxiolytic. Health insurance for Medicare. This is a health insurance for low-income people of all age. Join federal state program, eligibility and benefit vary. Considerable from state to state. Pay for nursing home care For a patient who reach spent down threshold, eligibility is based on modified adjusted gross income. Many low-income individuals who qualify for Medicaid do not receive it due to difficulty in navigating the application process or due to lack of understanding the plan or its benefit. Doable eligibles, it is term for 90 million Americans who qualify for both Medicaid and Medicare. Most Medicaid program pay Medicare Part B primes, and some pay Medicare deductible and co-insurance. Several states offer fixed capitation payment. To manage care organizations that coverage doable eligibles. Doable eligible who qualify for nursing home care should be considered for referral to program for all inconclusive care of elderly. This non-specific candidate community coordinate community based care to help older adults continue to live at home. Longer-term care insurance. More than 3 million Americans have long-term care insurance policy. These policy pay for less than 2% of all nursing home care delivered. Growth of long-term insurance sector has been limited due to higher primes, customer unable to long-term care in the future. And the customer adopt about policy ability to cover future cost for longer-term care. Accountable care organization. It is a group of the physician and hospital that coordinate voluntarily. It is a goal to provide high quality care, high quality patient care, avoid duplication of service, prevent medical error. Successful ACOs share in the saving they achieve. Medicare for several ACO program through Medicare share program that help Medicare FFS program provide become an ACO. An advanced payment ACO model supplementary incentive program for selected participants in a share saving program. Pioneer ACO model for early adopter of coordinated care. Bundle payment for care improvement. Introduced by CMS in 2013. It is a Medicare payment where FFS separate payment for each service provided during a single illness or course of treatment that result in a fragmentation of the care and hazard coordination across the provider and care setting, rather than incentivizing quality and rewarded quality of service effort. So bundle payment for advantage. It is incentive for physician, hospital, and other provider encourage a provider to work closely together across all specialty and setting. Other important Medicare and Medicaid partial close do not whole in Medicare Part D. Extend the coverage for preventive care service, elimination of co-payment for some service, expansion of Medicare Medicaid, such as that of 60.7 million individual gain cover, including 2 million with doable eligibles. change in provider reinforcement, decrease for the Medicaid Advantage plan, increase primary care physician through Medicaid and Medicare. MARCRA is a traditional traditionally Medicare payment were based on FFS schedule, which were adjusted by gross rate or sustainable growth rate. SIGR required Congress to pass a temporary duct fix each year to advert cuts. MARCM replace SIGR with the quality payment program, which incentive value. Provider choose how to take a part of GBP based of the practice size, specialty, location, and the patient population to choose from. MIPS and alternative models. For MIPS, streamline recurrent individual program to work in one and is provide a burden that physician quality reporting system, value-based payment modifier, electronic health records incentive program. It adds a force component to promote ongoing improvement and innovation of clinical activity. These are force component of MIPS are the quality, cost, resource use, clinical practice improvement, and advantage care information. For alternative payment model, an approach that gives added incentive to provide high quality and cost efficient care. APMS can apply specific clinical condition to clinical condition, a care episode, and or population. For advantage APMS are a subtype of APMS and practice can earn more than taken on some risk related to their population outcome. In 2017, practice may earn about 5% of incentive payment by participating in advanced APM, such as comprehensive primary care plus. VA benefit provides service to all enrolled veterans. Once enrolled in veteran or in VA health care system, veteran can be seen at any VA facility across the country. That this facility or effort, like in patient hospital care, outpatient care, laboratory service, pharmaceutical dispensing, rehabilitation, mental health counseling, and custodial care. Most care are provided through VA facility and provider. Exception: veterans who are Medicare, the Medicare beneficiary can use the Medicare system as well. VA is partnering with outside provider to extend its service. In addition to those partnership, veteran choose a program allow veteran to with veteran choose card to receive care from eligible non-VA health care entity or provider. So it must be unable to schedule appointment within a 30 day of their preferred date or clinically appropriate date, or based on their place of residence. This is a resource for patient and family. and this is a resource for health care professionals. To summarize what we say with Dr. Tahani, Medicare comprise of four benefit part A, B, C, and D. Medicare part A cover hospital, subacute skilled nursing home, home health, hospice care, hospice service. Medicare part B cover physician, nursing practitioner, social worker, psychologist, therapist, laboratory test, and doable medical equipment. For part C, provide some benefit effort under Medicare Part A and B through Medicare Advantage plan, which are managed care plan. From a private insurer, most Medicare Advantage plans and also for the Medicare for Part D benefits. Medicare Part D cover some of the cost prescription medication. Medicap supplemental insurance plan for private insurers cover Medicare Part A and Part B, detectable and co-insurance costs, as well as preventive care and other health-related goods and services. Medicaid, it is a joint of federal and state programs. Provide health insurance to all people of all age who have a low income limit serving. Medicaid cover long-term care in nursing home for a patient who reach spent down threshold. Medicare reimbursement in a shift is shifting from a volume base to value based approach. That is all, and thank you. There is any question? Surely, Dr. Nadil will provide us with more information. Assalamu alaikum, Doctor.
Alaikum salam wa rahmah. Very good, excellent presentation, both of you. Thank you so much for this great presentation. It's a big topic, I know, and the slides will give you just a little bit of a picture of how you approach the topic with just a summary. But it's very important to know the financial in America, like how they get paid for the hospital, for the nursing home, for clinic, something like that. So in the future, hopefully you will understand that when you join the residency and you become attending. But thank you so much, Dr. Amal and Dr. Tahani. I appreciate any questions.
Thank you, Doctor. Yeah, go ahead, Dr. Nabil.
No, go ahead. I just want to go to the next topic. Go ahead. Thank you, Dr. Bayan.
Thank you, Dr. Tahani and Dr. Amal. Next, we have Dr. Lena Alatta. She's going to talk about her experience at Mayo Clinic, the fellowship, research fellowship program at Mayo Clinic. Go ahead, Dr. Lena.
Hello, everyone. Ramadan Kareem. Can you hear me?
Yes, we do.
Okay, so I will be presenting about research fellowship in USA, especially at Mayo Clinic, with the requirement and how you can join. So sorry. So I will start talk until the slideshow is on. There is a lot of places that you can find a research position in US other than Mayo Clinic. you can look for Harvard, USF, Cleveland Clinic, university programs. If you don't need visa, you can look for Johns Hopkins. But if you are needing visa, Johns Hopkins has like, sorry, this. Johns Hopkins will require a sponsorship from institution to afford your visa, J1 visa. What you can do is going to Mayo Clinic main faculties page. Sorry, just 1 minute. Okay. You can go with this Mayo Clinic faculty profiles webpage, and then you will find their emails here and send email. You always try to make the email so personalized, like, dear doctor, I'm really interested in research position at your lab. In Mayo Clinic, you can find basic science research, translational research, and clinical research. So make sure that you highlight the kind of research that the doctor is undergoing when you are applying or sending email to a doctor, showing your interest in this email, in this position. After you have your interview with the doctor and you are proceed to the application, or when you have your position and you are going to your visa, you will need to have 3 letters of recommendation sent to Mayo Clinic HR. You will need a vaccination form. You will need health insurance, and you will need English language proof. The English language proof, the doctor, when he or she is interviewing you for the position, can make a quick assessment and send the form to the Mayo Clinic. Okay. Let's see here. So if anyone has a question, because the PowerPoint is going now, I'm so sorry for that. But if anyone has a question, I am really happy to answer.
Yes, Dr. Lena. My name is Maya, and yes, I want to explore this option. Like as you mentioned, regarding the letter of recommendation,
Okay.
like if I'm going to apply in geriatric medicine, is it compulsory I have to give 3 letters of recommendation from geriatric medicine?
No. You can have like from your university, dean, any doctor that has worked with it. That's one thing, that the letter should be letterheaded letter, like with the hospital logo on the letterhead.
Okay, means that it's a personalized, right?
Yes.
Okay, thank you.
You're welcome. Any other question? I can check on the chat.
And Dr. Lena, my next question, like if, for example, if I'm going to apply in basic sciences, so which letter of recommendation should I upload for that specific position?
Okay, let me tell you that the letter of recommendation is not mandatory to be for like the position. They just need a letter of recommendation for HR. So most of the time, if you are accepted from the PI or your primary investigator, it's just like a paperwork to have a letter of recommendation. So it doesn't matter who writes your letter of recommendation.
Oh, okay. Thank you so much.
You're so welcome. Any other question?
So, Lena, thanks for presentation. So you need to be in person, is that correct?
How? Sorry, for the
Yeah.
research?
For the research position, you need to be down in Florida or whatever context there is in Minnesota. So you need to be in
Yes.
person.
When they are, when you're going to accept, they can process your visa and come in person. I didn't see anyone who can work remotely from other country.
Excellent. And what about the topic? You search the topic yourself, or they will assign you some topics, they give you ideas or products like tasks, how does it work?
Yes, the main thing is according to the lab or the doctor you are working with. Some doctor can have basic science lab and have another clinical research. And always about, they always have like a plan, like something going on, clinical trial, research, but you can share your interest in other things like, okay, I like this case, I want to write a case report about this, I want to make a retrospective study about this. As long as you're doing your main job in a perfect way, they can help you and guide you in doing another more papers.
Thanks. And maybe you mentioned it, but it's paid or unpaid job?
Actually, it's unpaid job most of the time, especially if you are on J1 visa. And in fact, that when you are applying to the J1 visa, they will ask you about a proof or of income, like there's someone is sponsoring you in order to give you a visa.
So when you go to Florida, for example, you need to work with them, but you need to also secure some other work to support yourself, basically. Is that correct?
Actually, that's the matter also. The J1 visa is restricted to the institution. So you can't work in another place. You just have to, that's why they will ask you about minimum wage or minimum income to be in your budget before you enter the US or before they are accepting you in this position.
Yeah, so the support for if you are coming from overseas, you need to show the support that someone, if you are here in the US and you have visa, no problem, like you are citizen or you have green card, then you can go to Florida, you can find another job while you are working with Mayo. So some of the fellows in the past, they work like in the weekend,
yes,
in other places so that they can pay rent, pay for food or something, and then make clinical job for free, just to get the
yeah,
research
that's
part.
true.
Thank you.
Yes, thank you, Dr. Nader.
Mihir has question.
Yes, can go.
Yes. Hello, Dr. Nadir. Hello, Dr. Lena. I have a question for you. So, as you mentioned about this doing this program on J1, can somebody who is on student visa can do it?
Actually, I'm not sure if somebody on a student visa can do that, because I work at Mayo Clinic in Florida, and most of the time the students are from University of Florida. They have their student program from there, but I'm not sure that it may change their visa to work here. Yes.
Because many of the student visa allows what they call is CPT, like a continual practical training. So under that, you are allowed to work for certain hours. So I was just wondering.
Oh, thank you. I don't think so here.
Sure. Thank you.
Thank you. Dr. Nod?
Hi, Dr. Lena. How are you? My next question is the Mayo Clinic research position state-specific, right? Only specific states provide that offer, or you can find it all over the US?
Thank you for the question. Yes, it's just on the 3 states, Minnesota, Florida, Arizona. This is a place you can find a research on their campus, the research positions. But you can also, if you are interested in like a research position in a specific state, you can also check always for the university in that state. And if you have a green card, you can find a paid research position on universities. You just have to search about that.
Okay, thank you.
You're so welcome.
Hello, Lena.
Hello.
Thank you so much. Yeah, go ahead. Ryan.
Thank you so much, Dr. Lena. Next, we have Dr. Mihir.
You're so welcome.
Hello,
No problem.
everyone. Hello, Dr. Nadir. I'm going to share my screen. Okay. Can you all see the screen?
Yes, Dr. Mihir.
Okay. Let me. So, good afternoon, everyone. Thank you so much for having me today. And today I'm going to briefly describe the physical therapy practice in general and its implications in the geriatric population. I felt that even though we discussed on and off about some physical therapy topics in the past 1 year, and I felt that I probably wanted to actually describe more in detail and how it's all aligned with medical practice, especially here in the US. So today I have few agendas in place, and one of the just going through the guidelines, practice settings, scope of practice, physical therapy roles in primary, secondary, and tertiary care, and also in preventive care. Next on the agenda will be geriatric physical therapy, mostly discussing about optimal aging, slippery slope of aging. I don't know that if this has been discussed before here or not, but I just wanted to go through this again. Need for physical therapists in geriatrics, clinical decision making in geriatric physical therapy, and objectivity in use of outcome tools. So I actually also wanted to go through physical therapy in various settings, but because of this is going to be too lengthy, and I don't think I would be able to cover everything today. So I really want to cover these topics like physical therapy in acute, post-acute, hospice, home health, and health promotion wellness. I want to address that. So I think probably in near future, I would like to do so. So let's come to the overview of physical therapy practice. In practice settings, PTs or physical therapists, they practice in a broad range of inpatient, outpatient, and community-based settings such as hospitals, outpatient clinics, rehabilitation facilities, skilled nursing, extended care or subacute facilities, home care, education or research centers, schools, playground, hospice services, corporate or industrial health centers, industrial workplace or other occupational environments, athletic facilities, fitness centers, and sport training facilities. So when we talk about the scope of practice, physical therapists are, they provide services to patients, clients with impairments, functional limitations, disabilities, or changes in physical function and health status resulting from injuries, disease, or other causes. PTs also interact and practice in collaboration with a variety of professionals such as physicians, dentists, nurses, educators, social workers, occupational therapists, speech language pathologists, and other personnel involved with patient-client care. They also identify risk factors and behaviors that may impede the optimal functioning. PT also provides prevention and promote health, wellness, and fitness. Also consult, educate, engage in critical inquiry, and administrate by providing consultative services to health facilities, colleagues, businesses, and community organizations and agencies. PTs also engage in research activities, particularly those related to substantiating the outcomes of service provision. This is more in terms of the administrative services, and also they direct and supervise the physical therapy service, including support personnel, for example, PTAs, physical therapy assistants, aid, and restorative staff. So roles in primary, secondary, and tertiary care. Roles in primary care. Primary care can encompass myriad needs that go well beyond the capabilities and competencies of individuals, caregivers, and that require the involvement and interaction of varied practitioners, and which is not limited to first contact or point of entry into the healthcare system. On a regular basis, PTs who work in different settings, they assist patients, clients in restoring health, alleviating pain, examining, evaluating, and diagnosing impairments, functional limitations, disabilities, or change in physical function and health status resulting from injury, disease, or other causes. A primary care team may function more efficiently when it includes physical therapists who can recognize musculoskeletal and neuromuscular disorder, perform examination and evaluation, establish a diagnosis and prognosis, and intervene without delay. When I say diagnosis and prognosis here, diagnosis we establish more in terms of physical therapy diagnosis, which sometimes or most often time they are different than the medical diagnosis. I will give you example. So when you have in any setting, if you say post-acute or like subacute, excuse me, or outpatient, when there is a patient with a stroke or a post-CVA, we see that medical diagnosis can be, post-CVA or status hemiplegia status post-CVA. That is a typical medical diagnosis. When we assess the patient, we come up to the diagnosis of either that can be a gait abnormality or unsteadiness on feet or muscle weakness. These all can be a diagnosis, and they have a valid ICD-10 codes. Now, next one is with physical therapists functioning in a primary care role and delivering early intervention for work-related musculoskeletal injuries. Time and productivity lost due to injuries may be dramatically reduced. As clinician, physical therapists are well positioned to provide services as member of primary care teams. Next is roles in secondary care. So patients with musculoskeletal, neuromuscular, cardiovascular, pulmonary, or integumentary conditions may be treated initially by another practitioner and then referred to physical therapists for secondary care. So this is actually most common type we see in a practice. Physical therapists provide secondary care in a wide range of settings, including acute care and rehabilitation hospitals, outpatient clinics, home health, and school systems. Roles in tertiary care. This is provided by physical therapists in highly specialized, complex, and technology-based settings. For example, like heart and lung transplant services, burns units, or in response to other healthcare practitioners' requests for consultation and specialized service. For example, for patients with spinal cord lesion or closed head trauma. Any questions so far? Okay. Next one is preventive care. So physical therapists are involved in preventive care, assist to reduce cost by helping patients, clients, by achieving and restoring optimal functional capacity, by minimizing impairments, functional limitations, and disabilities related to congenital and acquired conditions. They also help by maintaining health, thereby preventing further deterioration or future illnesses, and create appropriate environmental adaptations to enhance the independent function. There are three types of prevention in which physical therapists are involved, pretty similar as primary, secondary, and tertiary role. So primary prevention is preventing a target condition in a susceptible or potentially susceptible population through such specific measures as general health promotion efforts. So this is more like when somebody either in the long-term care or somebody lives in an assisted living facility or independent living facility, and when they feel as a older adults, they feel that they are just declining in general and they feel like they need to maintain their level, so they can always contact the physical therapist. Many states in United States allows what we call as a direct access, means they may or may not require prescription from the physician or other healthcare practitioners right away, especially for evaluation. Many state allows the physical therapist to treat patients without prescriptions for first 10 visits, and it's all depends upon their health insurances. So comes to the secondary prevention, decreasing duration of illness, the severity of disease, and number of sequelae through early diagnosis and prompt intervention. So that is also, this is most likely we see in subacute care, where there is a short-term rehabilitations, and patients or clients are there to improve their functional ability. At the same time, we focus on decreasing that duration of illness and improving their quality of life. Tertiary prevention is limiting the degree of disability and promoting rehabilitation and restoration of function in patients with chronic and irreversible diseases. Many times with the patients with contractures, if you see, or patients with prolonged bedridden conditions, many of them like certain like quadriplegia or certain conditions, these kind of preventions we usually put into action. Examples of prevention screening activities in which physical therapists engage include identification of lifestyle factors, for example, amount of exercise, stress, weight, that may lead to increased risk for serious health problems. Identification of children who may need, this is again more general, so I thought that I would add this. Identification of children who may need an examination for idiopathic scoliosis, identification of elderly individuals in a community center or nursing home who are at high risk of falls, identification of risk factors for neuromuscular skeletal injuries in the workplace, pre-performance testing of individuals who are active in sports. Examples of prevention activities and health, wellness, and fitness promotion activities in which physical therapists engage, that includes back schools or workplace redesign, strengthening, stretching, endurance exercise programs, and postural training to prevent and manage low back pain, ergonomic redesign, strengthening, stretching, and endurance exercise programs, postural training to prevent job-related disabilities, including trauma and repetitive stress injuries, exercise programs including weight bearing and weight training to increase bone mass and bone density, especially in older adults with osteoporosis. Exercise programs, gait training, and balance and coordination activities to reduce the risk of falls, the risk of fractures from falls in older adults, exercise programs and instructions in areas, activities of daily living, so like self-care, communication, and mobility skills, required for independence in daily living and instrumental activities of daily living, IADL, that are important components of maintaining independent living, such as shopping and cooking, to decrease utilization of healthcare services and enhance function in patients with cardiovascular or pulmonary disorders. Exercise programs, cardiovascular conditioning, postural training, and instructions in ADL and IADL to prevent disability and dysfunction in women who are pregnant. Broad-based consumer education and advocacy programs to prevent problems. For example, prevent head injury by promoting the use of helmets, preventing pulmonary disease by encouraging smoking cessation. Exercise programs to prevent or reduce the development of sequelae in individuals with lifelong conditions. Now, next one is geriatric physical therapy. So we'd like to start with optimal aging. In mid-1980s, the term successful and usual aging first introduced as a mechanism to remind practitioners and researchers that the typical changes in physiological functioning, like a usual aging process observed in older adults, are quite variable and generally represent a combination of unavoidable age-related changes and modifiable, which is avoidable lifestyle factors such as physical activity, nutrition, and stress management. Few years later, key components of successful aging was further clarified and identified as absence of disease and disability, higher cognitive and physical functioning, and active engagement with life. Brumel-Smith defined optimal aging as the capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual, to one's satisfaction and in spite of one's medical condition. This recognized the importance of optimizing functional capacity in older adults, regardless of the presence or absence of the chronic health conditions. Functional limitations associated with chronic health conditions often lead to a vicious downward cycle with increasing level of disability, which leads to greater deconditioning that further decreases the functional ability. This declines leads to secondary conditions associated with chronic conditions and often to additional new diseases. Physical therapists can be particularly instrumental in reducing the disabling effects of chronic disease process by promoting restorative and accommodative changes that stop or reverse the vicious downwards functional cycle, allowing the individual to achieve optimal aging in the presence of chronic health conditions. Now, next one is slippery slope of aging. So slippery slope of aging is closely linked to the concept of optimal aging. So the slope was originally proposed by Schwartz, which represents the general decline in overall physiological ability, which Schwartz defined as a vigor that is observed with increasing age. So here's the slope, here's the graph. If you see on the x-axis, there is a age, and on y there is a vigor, means a physical ability, or physiological ability. So slippery slope of aging depicts the general decline in overall physiological ability, which observed with increasing age, and it impacts on function. So the curve is arbitrarily plotted by decade on x-axis, so the actual location of any individual along the y-axis can be modified regardless of age based on lifestyle factors and illness that influence physiological functioning. Schwartz has embedded functional status threshold at various points along this slope, as you can see in this graph. Conceptually, these thresholds represent key impact points where small changes in physiological ability can have a large impact on function, participation, and disability. These four distinctive functional levels are descriptively labeled as fun, function, frailty, and failure. Now, fun, the highest level, represents a physiological state that allows unrestricted participation in work, home, and leisure activities. The person who crosses the threshold into function, who goes from fun to function, continues to accomplish most work and home activities, but may need to modify performances and will substantially self-restrict leisure activities like fun activities because of declining physiological capacity. Moving from function into frailty occurs when managing basic activities of daily living like walking, bathing, toileting, eating, etc., that consumes a substantial portion of physiological capacity with substantial limitations in ability to participate in community activities and requiring outside assistance to accomplish many home or work activities. The final threshold into failure is reached when an individual requires assistance with basic activities of daily living as well as instrumental daily activities and may be completely bedridden. The concept of functional threshold and the downward movement from fun to frailty helps explain the apparent disconnect that is often observed between the extent of the change of physiological function, such as impairment, and changes in functional status. The lifestyle changes, including increased exercise activities, may enhance the efforts for an upward movement along the slippery slope. Moreover, the further person is able to move above a key threshold, the more physiological reserve is available for protection from an acute decline in a physiological system. A major role of physical therapy is to maximize the movement-related physiological ability, like vigor, of older adults, patients, or clients, to keep them at their optimal functional level and with highest physiological reserve. So the need for physical therapists in geriatrics. So the first wave of baby boomer generation turned, I apologize for misspelling here, turned age 65 years in year 2011. This group born past World War II is much larger than its preceding generation, both in terms of number of children born during this era of 1946 to 1965 and increased longevity of those in that cohort. Interestingly, although health services researchers have long forecasted the substantial impact of this demographic shift on the healthcare system and encourage coordinated planning efforts, inadequate preparation has been made to assure sufficient number of well-prepared healthcare practitioners to meet the needs of this group or this large group of older adults. The 2008 landmark report of Institute of Medicine Retooling for Aging America provides a compelling argument for wide-ranging shortages of both formal and informal healthcare providers for older adults across all levels of healthcare workforce, like professional, technical, unskilled direct care worker, and family caregiver. These shortages also include shortages of physical therapists and physical therapy assistants. The report provides numerous recommendations for enhancing the number of healthcare practitioners, and the depth of preparation of these practitioners. A sizable proportion of caseload of most physical therapy practices is the older adults. A recent large-scale physical therapy practice analysis reported that 40 to 43% of the caseload of physical therapists aggregated across clinical practice settings are percentage patient ages 66 years old older. I work in community rehab and my on an average patient group, their ages is just above 75 years old. So I have more like older adults from aging from 60 to 90, 98. The oldest one I'm currently treating is 98 years old. Undoubtedly, with very few exceptions, the majority of the caseload of the average physical therapist will soon consist of older adults. Despite this, physical therapists still tend to think about geriatrics only as care provided in a nursing home or perhaps in home care. Although these are major and important practice settings for geriatric physical therapy, physical therapists must recognize and be ready to provide effective services for the high volume of older adult patients across all practice settings. Every physical therapist should be well grounded in the science of geriatric and gerontology in order to be effective in making evidence-based clinical decisions related to older adults. Clinical decision-making in geriatric physical therapy. The primary purpose of physical therapy practice is the enhancement of human performance as it pertains to movement and health. Providing a framework for clinical decision-making in geriatric physical therapy is particularly important because of the sheer volume of information that must be brought to bear on a clinical decision. The enablement and disablement concept of the World Health Organization's International Classification of Functioning Disability and Health model of disability are also incorporated using IF language to communicate the process of disablement and placing a substantial emphasis on describing the and explaining personal, medical, and environmental factors likely to enable functional ability or increase disability. Now, objectivity in use of outcome tools. So older adults becomes increasingly dissimilar with increasing age. A similarly aged person can be frail and reside in a nursing home or be a senior athlete participating in triathlon. This similarity cannot be attributed to age alone and can challenge the therapist to set appropriate goals and expectations. Functional markers are useful to avoid inappropriate stereotyping and further and undershooting of an older adult's function potential. Functional tests, especially those with normative values, can provide a more objective and universally understood description of actual performance relative to similarly aged older adults, serving as a common language and as a baseline for measuring progress. For example, describing an 82 years old gentleman in terms of gait speed, 0.65 meter per second, a 6-minute walk test of 175 meters, Berg balance test of 26 out of 56, and a timed 5 repetitions chair rise of 0 provides a more accurate description than an older man who requires mud assistance of 2 to transfer walks with for 75 feet with a walker and whose strength is within functional limit. Reliable, valid, and responsive tests appropriate for a wide range of abilities enhance practice and provides valuable information for our patients and referral sources. That is it for today. Thank you so much for listening me, and I apologize for any misaccuracies or not able to speak fluently today. Any questions?
Thank you so much, Dr. Mihir. Thank you. This is excellent presentation. Any questions for Mihir?
Thank you so much, Dr. Nadir.
Thank you so much, Dr. Mihir. It was a great presentation.
Thank you.
No problem. So next we have Dr. Nafisa. She's going to talk about her experience in her presentation, the poster presentation at American Medical Directors Association. So here you go, Dr. Nafisa. Go ahead.
Hello, everyone. Thank you, Dr. Rayan. Hello, Dr. Nadir. Hello, everyone. I'm sorry that for the inconvenience, and I was late a little bit. Actually, I missed the data that I already prepared, so I'm trying to. So, do you guys see my screen clearly?
Yes.
Okay, great. Thank you. So I'm going to talk about my experience at the PLTC AMDA. So as you see, that's it was March 9 from 9 to 12 at Tampa, Florida. So what PLTC actually stands for, which is the Society of Acute and Long-Term Care Medicine, and AMDA, it's American Medical Director Association, which is that's an annual conference every year. Basically, this year was in Tampa, Florida, and I think they have another one scheduled for November in Texas, and I believe that. So basically, I want to talk first from my experience about how to create your poster, because that's very important when to present your poster. So first of all, at the time when you start preparing, that's very important, because every time you're going to review your poster, you will find mistake. You will get new ideas actually to add. Like for me at the beginning, that's like a new experience for me. So every time I got to just to get to see what I'm doing. Actually, I get new ideas. And that's actually helped me a lot in create my final poster. So the title is very important. It has to be catchy. Like during my experience, I see people, they coming by, they just stand like because of the title, you know. That's very important. It has to be catchy. That's also for like if you want to win an award, the judge will actually, that's how they score you about the title, the layout of the poster, the colors, the picture that included. So the layout is very important. It has to be like people, they come for 1 minute and they want to get an an overview exactly what's the poster about. So when you make it simple and it's clearly outlined, the aim of your study or your case, the conclusion is also, and the pictures is very important. That's basically, if it's simple enough, like if you can see from this one, my case, my poster is actually about a case presentation about the early psychiatric manifestation of Parkinson's disease, which is it's a patient presented with anxiety as an early presented symptoms of Parkinson's disease. So in this one, everyone was coming and just staying in this picture only. Why? Because this picture is actually explaining why anxiety in Parkinson, what could be the cause of it, how targeted. So that's also important. And one of the judge also, she liked the color. She said it's like when you look at it, it's nice. That's what it catch her. And also when the logo that you add, so clearly here I add AMDA, and also I add Michigan State, which is it's telling me where I'm coming from or where I'm affiliated with. So that's also something important to add. What is coming about printing the poster? Also, there's like at the UPS store, there's Staples, FedEx. I got experience with UPS and Staples. FedEx, I saw people. Actually, the quality I didn't like it in FedEx. How the poster is like, and for Staples, it's kind of expensive. I did the poster with them last December, and it's actually like one with a handout is cost me near $100, but there was with the same quality in UPS. I got two posters with handout and it cost me $100. So that's also another thing to consider when you come into printing your poster. Okay, so how to present your poster, that's also important. As you see here in my picture, I have my poster and I put in the table, I put in the table some handouts, so that's anyone who would like to take. And also I added my contact information there, so that's also important. And regarding also the how to present, basically, if you put a lot of pictures and talk about those pictures is more important than just adding information, which is usually people, they don't stand and just read unless there's something that, like for example, in case of it's not obvious here, but for me, the aim, I actually highlight it. So that's what they do. They read the title, they read the aim, they read the conclusion, and that's it. So in me, by presenting the poster, I'm talking mainly about my picture, what's the finding, and actually those pictures of the patient I added, it's like 2 weeks. I took those pictures 2 weeks from presenting my poster, and that's one of the things that's like the judge actually comment on that, which is being update my poster. And so that's basically what about the poster that I'd like to talk about. Let me try to see if I can add another thing here. Okay, so that's just some pictures about the place itself. That's where the poster session. I had this me with my two poster. They're very nice. They accommodate for me that to put the two poster near to each other, so I don't have to move from one place to other place. So that's just some people that here, and also like you can see how those the posters assigned, and in the same place actually it's like they have also like some pharmaceutical company. There is some they're talking about like finance for the physician and stuff like that. So that's also, it's a very nice for everybody. And also they have some games in the same place, which is so funny. Okay, so that's also the social, which is everybody get to connect with each other and connect with new people. That's some picture of the just company over there. That's a sample of my poster. Also, yeah, so for this picture here, I have this picture. I couldn't add it in my poster. So that's exactly helped me to kind of explain for the audience exactly how the anxiety being connected to Parkinson's disease. So I get a picture about the nucleus, rough nuclei, and like how that's firing in order to be connected with Parkinson's disease. So that's also something everybody like, they like this idea. So that's my badge. They give it to you. For me, it's an attendee. They have a lot of courses included for the 3 days. So basically, they add for everyone here every course that will be attending. And that's the exhibit hall. That's where the poster session. And that's some of the presenter. We have Dr. Shema. She's here with us. And basically that's it for this one. Let me go back. All right. So thank you everybody for listening. I hope that I'll help you a little bit with your future poster. And Ramadan Kareem for everyone who's celebrating Ramadan. And thank you.
Thank you, Dr. Nafisa, and congratulations for your poster presentation.
Thank you. Thank you so much.
And that's it for today's meeting. The next is the projects update. So if you have any updates on your project, you can go ahead.
Before that, or you can jump, I'd like to thank Dr. Nafisa as well. Congratulations for your work and all that work on this and other posters. Congratulations. I think you presented 2 posters of how many at AMDA, Nafisa?
Yes, I presented 2 of them, and nice that they actually accommodate me to put the 2 posters next to each other, so I don't have to run from one place. It kind of I couldn't, like, there's no one of my team member actually was able to go with me. It kind of sometimes difficult because a lot of people will be staring at the 2 posters at the same time, so I wasn't able to present for everybody. Some of them they actually see other posters and they came back to me, and some of them they just read and go. And also that I would like to add that regarding our fellowship program, there's a lot of people when they come in, they see, okay, are you with Michigan State University? And then I explain our program. So they're like, that's very interesting. Do you have guys a website that we can visit and see? So that's something I encourage you, especially in LinkedIn profile, any place if we have like a website that people can actually go and see our project there. Everybody shares experience there, so
yes,
that would be
we
nice.
Have one,
Also,
but it's not the official website. It's just like the publication. Yeah, we can share the link for that. Yeah. Thank you. Excellent. We are working on getting a website for the fellowship and the program.
okay. Thank you so much.
Thank you. That's excellent work, and thanks for presenting your work and your team's work. Excellent. And thanks for sharing your experience with us. So now I'd like to ask any of the fellows who managed to fellowship or residency, can you share some of the tips? And I think we didn't share it last week. I start with Ryan. Congratulations for all of you there. Go ahead, Ryan.
Assalamu alaikum. So this was my second time applying, and last year I got 2 interviews, and this year I got 9 interviews. And I believe that was mainly due to connections, and also I rewrote my CV. Like last time it wasn't organized. This time, like I made sure to like draft it multiple times and ask my mentors and colleagues to review my CV. So I believe perfect eras writing like affects your ability to get interviews. Excuse me. And also the second thing that happened to me was like I had a mistake at my ERAS application. Like I upload 1 letter of recommendation twice. So I ended up having 3 letters of recommendation instead of 4. So the very next day of application, I emailed all the programs with the missing letter of recommendation. And I think that gave me like more exposure as well. And yeah, and also connections. Like I reached out to multiple people, like not only Sudanese people, like every ethnicity. And I believe my LinkedIn account like helped me a lot. I used to connect with the one sec, sorry. I'm sorry about that. So yeah, so LinkedIn helped me a lot. I connected to like all PGY 1, 2, and 3 on all programs that I applied to. Like I used to go to the website of the hospital and see the residents and search them on LinkedIn and connect with all of them. So one of them or two will connect with me back. And yeah, so connections and write your CV very well. And yeah, that's it. So if you have any questions, feel free to ask me.
Thank you so much, Dr. Ryan, for sharing your experience and tips. Yeah, I think LinkedIn can help. So if you have any account, please use it. And if you don't, please create an account and hopefully you can find more information, make some connections. And same with other platforms like for in the future, for example, if you want to share some of the posts that you did with Twitter or other platforms that is social. Or if you talk to them, you can refer them to your account so that they can verify you did this and they can work, they can make contributions or something like that. Thank you so much again, Dr. Ryan. From the group here.
Oh, thank you for giving me this opportunity. Actually, the research fellowship like helped me a lot too. And all my in all my interviews, I was asked about the fellowship, like all of them. So thank you so much for the great letters of recommendation and for this opportunity and for your guide throughout the way. I really appreciate it.
Thank you. You did the whole work. So everyone for your talk and wish you all the best time. Anybody else?
Thank you.
I know some here they matched or at least they secured some residency or fellowship, and some of them working on getting or applying to other spots. So I would encourage all those who seek further. Some of the program might have empty spots. This happened to me in the past. Both times when I started residency, the first time I felt the gap because at that time they had an unexpected position for I think. So I went to university. I did for the second year also and had an opportunity to fill unexpected position here and Michigan State. So I came to Michigan. So usually it opens the allows us in mid of May, early June this time. some people might have some memory issues or maybe visa issues or some topics here and there. So the program will be searching for some ready to start with applicants or candidates. So you can look out. The second thing is apply for fellowship that accept medical graduates with some experience. But I think you need some visa or you need some US citizen or green card for this position. So if you have some, that would be helpful along with the step 3. Thank you, guys. Anyone else you want to share?
Hey, Dr. Nadir, I just want to add one thing. Regarding the poster, we have Dr. Ala Abdusamad, she's one of our senior. She's very helpful. She actually liked to do the poster. She enjoyed that, and I really appreciate her help. So for anyone that want help or want to be reviewed or want an opinion about that, he can reach out to her. She is very nice. She will do that. Like she's actually enjoyed that, so she will be happy to accept or even review their poster.
That's great. Thank you so much for raising this point, Rita. And I will refer Ryan Mohammed, which is here. Congratulations for your process, your work hard, and your work will be presented at the American Military Association or something like that in Boston. So maybe if you're still working on your process, you can use help these for the some information. So, thanks. Dr. Ala also worked and presented some of the courses in the past in one of the conferences. So she has some experience with any other updates as far as projects going on with you guys? If no, we still reviewing the application for the new batch. We will accept those who meet some of the criteria, and so hopefully we'll help them as well. We will be the seniors for them, so I expect and I request kindly to help them as much as you can whenever you have some time. I know some of you may be busy with family obligation or work or other stuff in your life. So if you have the experience or if you have the knowledge, please share this with the new coming class. I really appreciate that. So thank you so much. I'd like to thank all the presenters from today's presentation. Thank you so much, and thank you, Dr. Ryan, for moderating this meeting. I know you're busy with your as well, but thank you for organizing everything. The high to guys.
Thank you, Dr. Nadir, for giving us this opportunity.
Thank you. So if you have any questions, let me know. Shoot me an email, contact me in the text, call me. I'll be happy to answer. And we'll see you next year. Thank you. Assalamu alaikum. Ramadan Kareem. Happy Ramadan.
Alaikum assalam wa rahmatullah. Assalamu alaikum.
Thank you, Dr. Nadir. Have a great day.
You're welcome.
Thank you so much, Dr. Nadir. Have a great day.
You're welcome. Thank you.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Bye.
Thank you. Bye-bye. Bye.
Thank you, Dr. Nadir.
Thanks for the presentation. Yeah, have a great one.
Thank you.
السلام عليكم ورمضان كريم.
أنا if you're still there. Alaikum salam. Ramadan Kareem.
Hello,
Thank
Dr.
you.
Nader. How are you?
Very good. How are you?
I'm fine, thank you.
Excellent. I think you have some, some other fellows working on the question, the Arabic
So-
version, or no?
I didn't start yet, but I'm so excited for that. So we are doing great. Our numbers of downloads is increasing. It increases slowly, but every day there is an increase. Like now we reached, I think, 49 downloads, and we have downloads from countries like France, Oman, United Kingdom, and we're still maintaining the 5-star rate. I think this is great. Also, like 2 days ago, I presented my application to my professor at university. She's an endocrinologist practicing in Sudan. She liked the idea very much. She was very impressed with that. And she encouraged me to translate this to Arabic because she thinks this is really going to help the Sudanese patient population. So yes, soon, inshallah, I will start this process.
Yeah, no hurries. Thank you so much. No worries. No hurry. I really appreciate for the update, and I wish you all the best. It's great that you have some downloads from other countries as well, and I'm glad that you shared with many for the endocrinologist. Thank you.
You're welcome, Dr. Nader. Thank you for the great opportunity.
Anytime. Thank you. Have a wonderful day. Assalamu alaikum.
Wa alaikum salam.
Dr.
Ramadan
Mufaz,
Mubarak. Thank you.
thanks. Dr. Mufaz, are you still there?
Hello, Dr. Nader.
Hello, how are you?
Good evening. I'm fine, Alhamdulillah. How are you?
Very good, alhamdulillah. Did you have any updates?
Yes, regarding the application, the app, we've kind of finished the first half of it. I would like to share my screen because I'm not able to.
Oh, sure.
Yeah, it will be easier for me. So our app, we want it to be solely for the parents. So it will kind of guide them towards which sort of vaccine to be needed for at each age. So right now it's all for the US citizens. They would come in, they would choose their that they live in USA, and then if, for example, the child is 1 month, when they choose 1 month, they will have the recommended vaccine. And then we wanted, I think that's the part that we finished, and then we want to add two services. That's the information on vaccines, which will include the CDC guideline, and then some researches that shows the benefits of each vaccine and why it's needed. And then we want to add the basic information for children of, for example, what parents would need to do, or what they would need to know when they have a child, when to vaccine. And for example, other than the vaccine, there's like vitamin K, there the period for each breastfeeding and what type of food to avoid. And for example, if they need to avoid water due to its harmful effect on the child. So that's what we want to do. That's the services.
Excellent. This is great. Yeah, wonderful work.
Thank you.
Awesome. Perfect.
But I have a question. How do we add our informations in these? Because I have the idea of the spreadsheet, but then when I wanted to add the CDC guideline, it comes to me as links only. It doesn't come up as.
Yeah, so if you click on the, which on the left side, which one of these four you want to work on? The info on the vaccine?
Yes, information of vaccine.
Okay. So if on the right side, if you go to info on vaccine, the title on the right side, one more. Right,
Okay.
right. No,
On the
all
right
the way
side?
up there. Up.
Yes.
Yeah. Click on info on vaccine.
So I
No, no,
write
no,
info
not the title. No, not the title. Up one
here.
3 lines. Yeah, click on it.
Okay.
Click on it. Is it? Yeah. So here, on the detail, so you highlighted the blue cards down, right,
Yes.
not line. Go to the 2 step on the to the right details.
Details.
So these are the views. So how you want your view to be, your app to be viewed by the user. One option is the card view. It's like business cards. You want them to look at this card. It's kind of limited, but the detail view is kind of open. You can do many things with it. If you look at it on the other side, if you go all the way to the left side, component, all the way to the left, all the way to the left of the screen.
To the left side?
Yeah, this is the component where you can I click on the plus signs, you can add, and then you have many options to add the link. You want to add text, you want to add buttons, you want to add pictures, videos, anything will be here.
So to all follow each other as form of text. Yes.
Then the text, you can put the text here. You have switch text, view text, or so if you click on the text, you can edit that, and it will be on the right side. No, on the right side here, and click on it. Click on guideline, and then custom. No, up custom. You can custom that, or if you had it in your table, you can put it in your table. But what I mean by the table, if you go to the data in the middle of the screen up top.
Data?
No. Go up.
Yes.
Yeah, data here. This is the table that you have. So the first column is guideline, the second column is new column. And if you want to go to the right, click the plus sign. All the way to the right, click the plus. This will create another column. You can name it anything, and then let's say, and then click done. So if you click down here, you can add any comment.
Okay.
And then go back to layout. If you select here the text and the text here on the right side here, and then go down and the bottom. So these are 2 ways to get the information as far as the text. If it's one thing that you want to edit or show, and you're not gonna make changes, you can customize. If you are using some, let's say you want to count the users' number for something is gonna be changing every now and then it's better to use the data, the table in the data, so that you can only change one place. So you go to the data, and then you add whatever you want to add there, and it will show up there in the layout. If that makes sense.
Yes, that makes perfect sense. Thank you so much.
You're welcome. Is it your question, or did I answer it, or you have?
No, that's the only question. Yes, thank you.
You're welcome.
Is there any suggestions for like services that we can add other than the information, the basic information?
What do you think, Amal?
I think it's great so far. At this point, I don't have any suggestion. I think it looks very nice so far. So just go ahead with that.
Thank you.
And if you need any help, I'm available.
Okay, thank you so much.
Time.
Thank you.
I do agree. So what I think is the best thing is to work on the functionality, the way you just did, like 4 pages or tabs, and then add the information. So this is the big layout for you, and how the functionality, how the user will click here, will go there, the way you just mentioned about the age and then the country. So if you build all this together, And then we can modify it. Let's say we want to add Sudan to the country. Then we will talk about how you can add this feature or whatever other features you want to add, videos, you want to add links, you want to add something. It will be as details later on. So it's kind of making it better and better each time. But the idea is to build the way you are doing now. If you have all the information, just put them and then play with the layout and see. If we complete this part, then adding other new features or improving it will be the next step.
Yes,
If
thank
that
you.
makes sense.
Yeah, that makes perfect sense. Yes, thank you so much. And Ramadan Kareem to everyone.
Ramadan Kareem. Thank you. Thank you so much.
Dr. Nader, I have a question.
Yes.
The videos in Arabic are very difficult to find, like videos that target patient education. So most videos are for medical students explaining the INR and like PT, PTT, and complicated scientific language. So I can't find an Arabic patient educational videos. My professor suggested that I add more video content to the application because she noticed that patients like to listen more than to read. And this is especially for patients who are illiterate, who can't read. So this is the suggestion that she gave me. Otherwise, she liked the application so much and she thinks that it's complete and she's going to recommend this for her patients. But I don't know where to find the videos.
Sounds good. So my suggestion is number one, we can create our own videos by saying what I mean is you already have the videos in English, right?
Yes.
So there is a way to get the text out of the video in YouTube. I think it's called the script or transcript. So if you get the transcript, put it in Google Translator and it will translate it to Arabic. Yes. The whole video will be translated into text for you. Then you can modify that according to, let's say, Sudanese or Egyptian or whatever area you are working in or targeting your audience in this area. Then find one of the fellows in this group, maybe, or some co-worker who can just create the video itself. So you and that fellow, you can work together to make YouTube video with the content already made, maybe modified a little bit to the situation of the patient population, and then create that, upload it to the YouTube, and then connect that to your app. So
yeah, this is a great idea.
And just using the whole available tools like the YouTube and create our own with the same data, but modify the video.
Yeah, I like the idea of creating our own videos, especially that we can avoid the copyright issues because Google Play really focuses on that. And so is it a good idea to ask my cardiology professor at university to just create this video for me?
You can, or you can ask some of the fellows who are interested. Let's say some might be interested in cardiology, or I know Akhila, she was interested in cardiology, but she did the Hindu maybe Urdu. But if there is any other fellows from Sudan, from Egypt, from Syria, who are interested in just general, let's say, internal medicine or in your case, geriatric or family, that would be great for them to work with you to create the video together, and then put it there. If the cardiologist is okay, I have no problem, but most likely he will have some limitation with them. They may not have time to create their own videos unless you help them or they have facility to help create videos. So approach your mentor there, see if they have the time and they can do it. If not, my suggestion will be to ask some of the fellows in this group to see if you can create a small team to divide the task into a smaller one, and it shouldn't be one person do all the work. The more people you have, just give them each one video or 2 videos to create them, give them videos back to you, and you just plug them out and put it down. They will be accredited, and then you will have the whole app put together, and they can put that in their CV or their suggestion that they help develop this app, something like that. So,
Yeah, this is a great suggestion. I like involving fellows so they can benefit from this. So yes, I will post in the WhatsApp group and see who's interested. Thank you so much, Dr. Nader.
you're welcome. Thank you. Thank you so much.
You're welcome, Dr. Nader.
Thank you, everyone, and have a good day. Have a good night. Ramadan Kareem. See you next week. Assalamu alaikum.
وعليكم السلام، رمضان كريم.
عليكم السلام.